Today we will discuss another interesting case of an M1 lesion. Welcome to Stroke Rounds episode 44.
59-year-old male patient. On first day, he developed sudden onset of numbness in his right leg at around 8:30 p.m. So he decided to consult a doctor on next day OPD. While examining at around 10 a.m., patient suddenly developed more severe motor aphasia. So the doctor decided to take an MR immediately.
So in a nutshell, the patient had initially had only mild numbness of the right leg, but no significant motor symptoms. But in the next 12 hours, while consulting a neurologist in his OPD, became totally aphasic. So he had a significant neurological deficit at that time. And this is the MRI done immediately after that. What does it MRI show?
MRI showed acute infarct with a diffusion restriction in anterior internal capsule with basal ganglia on the left side, along with the cortical watershed area diffusion restriction, suggestive of an embolic component in anterior and posterior part.
So what will be the conclusion based on this MR?
So since there is a watershed areas involvement, then a large vessel is involved on that particular side. Along with that, lenticulostriate involvement is also there. So that particular large vessel problem is affecting the lenticulostriate also.
So probably a lesion which is affecting both the lenticular striate as well as sending emboli to the cortex may be responsible for this, which could be an M1 lesion. So
the MR angio is showing normal carotids on both sides, and left side mid M1 segment is showing a filling defect.
So this is something similar to yesterday's case. In the previous episode, there is a disease of the M1 segment, but distally you can see the vessel.
Yes.
So there is flow, it is not completely occluded.
Now, the patient was referred here, and patient initially was taken for CT angiogram. The extracranial vessels was okay. These are the images, the coronal images, and the sagittal images showing the right and left carotids.
So this is the AP view, anteroposterior view. You can see both the common carotid, internal carotid, external carotid, the internal carotid. So this is interesting, no? So this is the internal carotid is external, and external carotid is if when you see anteroposterior. So this you should remember, especially while doing an angiogram. What is external is actually the internal carotid. External carotid means it is going into the external. It's outside the cranium. That's all. But no, location wise, this is exactly how it will look on angio also. So in the lateral view, you can see the internal carotid very well. There is no significant disease there.
This is the MIP images of the intracranial vessels.
So we'll try to read one by vessel. This
is the right
axial
internal
view.
Axial view, right internal carotid, dividing into that's pico, and that is a M1, right M1, which is essentially normal, and that is A1, right A1.
Okay. So this is a very interesting angio. We can see the very large PCOM continuing as a PCA. This is the M1 dividing into two branches. There is nothing significant on this. This is the ACA, and this is.
So on the left side, we can see almost normal carotid with the MCA, and there is a fill-in defect, almost the mid portion of left to M1 segment.
So it is very difficult to decide whether this is a narrowing or something else. So the patient was. So what does this show?
It's a coronal MEP image showing the almost the same findings. On the right side is essentially normal. On left side, we can see similar findings with the additional. There is fill-in defect in the mid portion of MCA,
and there is minimal narrowing of the origin of the A1 also. So what does it? And there is minimal narrowing here also. So there are some 3 areas of mild stenosis seen. Patient was taken up for an angio. So this is the right carotid angiogram, internal carotid artery, petrous segment, cavernous segment, the ophthalmic segment. The internal carotid, the circulation is normal. There is no cross flow to the opposite side. This is the left vertebral artery injection. You can see that the V4 segment there is a atherosclerotic lesion. Can you see this?
Yes.
So here it is dividing into, this is the superior cerebellar artery, and this is the posterior cerebral artery on this side. It is not seen on this side. You see only the posterior circulation filling on this side. Here, are you surprised?
No.
No. This is a fetal PCOM. It is filling from the anterior circulation, which we actually knew from the CT angio itself. So this doesn't mean that no, the PCA is occluded here. So that is why you should analyze the angiogram in full before coming to any conclusion. This is the left internal carotid angiogram showing the cervical carotid, petrous carotid, ophthalmic segment distal. So here you see there is an some abnormality. So that has to be studied in detail. So here you can, what do you see here?
Yeah, there is the diameter is not that much reduced, but there is translucency, like the opacification is less on that particular segment.
So here you can see it very well. So the you can see both the borders of the vessel very well, and there is some filling defect inside that. So what could this be?
It can be a thrombus,
It
and it
can
can
be a
be
thrombus. But so you see the normal vessel, and then there is some defect inside that, suggesting that this is likely a thrombus. You see the A1 which is
narrow.
narrow. This branch also there is origin of which is narrow. This is probably suggestive of intracranial atherosclerotic disease, but this lesion is suggestive of a not suggestive of a atherosclerotic narrowing. So, what would you do in this particular situation?
Uh, we will try
Yeah, there is a
thrombectomy.
thrombus there, and the patient has got a significant deficit also. This is on the left MCA territory. Patient is totally aphasic, even though the motor deficits are less. The patient has got significant neurological deficits. So naturally, this has to be tried to be either you have to open it, or so the first attempt was to do a thrombectomy and see if there is a thrombus, pull it out. So a standard Solumbra technique, a thrombectomy was done, standard river across, and this is the after that. You see that it has become
opacification is
almost much less. This has become much clearer. This was the narrowing which was there previously. So but the opacification has become much less, and a small clot was removed. You can see this. Another picture, another very close up picture showing that looks like almost like a normal vessel. So technically based on a MR angio, it is at times difficult to differentiate between an atherosclerotic narrowing versus a thrombotic occlusion or a dissection also. So the what is the learning point from this particular patient? So this is the two images now, one before showing that there was a thrombus inside, and one after thrombectomy. Clear? So what is the learning point from this particular patient? Number one, a patient with an M1 disease, if there are symptoms, the patient should be evaluated with a digital subtraction angiography to get a better understanding of the disease process. What could be the pathologies beneath a M1 disease? It could either be a atherosclerotic lesion producing a narrowing, it could be a thrombus superadded on the atherosclerotic narrowing or on a normal vessel. Third, suppose if there is a headache in an young patient, it could be an M1 dissection, either occluding the vessel or with a superadded thrombus. And the fourth, it could be a vasculitic illness. So to differentiate between these three or four situations, one has to definitely do a digital subtraction angiography and decide on the treatment. So comparing the previous case with this case, the previous case did not have a significant neurological deficit. And it was an atherosclerotic lesion. There was no superadded thrombus. So it was decided that, and the stenting of that lesion was technically difficult and likely to create complications. So it was managed medically. Whereas in this particular patient, the patient was taken up for a DSA, and the patient had significant neurological deficits. And hence, the patient underwent a thrombectomy. Thrombus was removed, the vessel was recanalized, and the patient aphasia significantly improved in the next 24 hours and was discharged on the fourth day without any neurological deficit. Please do share your comments, thoughts, opinions, and suggestions. And if you have any suggestions or opinions to make about this particular patient, please do let us know. See you next time with another episode of Stroke Rounds.